Hello, Hans-Björn.
Good morning, everybody.
Good morning.
How are you?
Good.
Okay, okay.
Good morning.
Morning, dear professor.
Good morning.
Good
Nice to
morning.
meet you. Can you hear me?
Yes. Yes, we hear you.
Can you hear me as well?
Yeah.
Oh, that's good. And
Yeah.
how do we do this, Dr. Stanila? Can I start by the first page? I lost you.
We start or wait to be at 9 o'clock?
Yeah, at 9 o'clock.
There are more than 3 minutes, yeah?
And I understand that you are the first speaker.
Yes, I'm the first speaker.
Yeah. So then maybe I can introduce you, or
Yeah, okay.
Okay. We have a few minutes, and at 9 o'clock we'll start.
yeah.
I must find my presentation. Share screen.
It is busy.
Doamna profesor,
Yes.
Da.
acolo deschideți unde erați în Zoom și acolo este share screen jos.
Yes, am văzut, dar trebuie să găsesc lucrarea mea.
Da, trebuie să o deschideți mai întâi, da.
Da, asta era
Bine,
problema.
bine.
Da, se vede?
Da, este. Eu o văd cel puțin.
Atunci este în regulă.
Well, dear guests, dear colleague, we can start today's session. I invite the moderators to start the session.
Thank you. Good morning to everybody.
Good morning.
My name is Hans-Bjørn Bakketeg. I am an optometrist from Norway, and I have been working in Moldova for many years. So UBS Moldova. I'm honored to moderate this session together with Professor Adriana Stanila. And she will be the first speaker in the topic of therapeutic approaches in neovascular glaucoma. So please, Professor Stanila.
Yes, thank you. I'm the first speaker. It's so early in the morning. I am very glad to be together with you all. In the next minutes, I will talk you about our experience in treatment of neovascular glaucoma. We all know that neovascular glaucoma is the very severe type of glaucoma caused by a variety of disorders like diabetic retinopathy, central or branch vein occlusion, or ischemic syndrome. It's a devastating type of glaucoma with very poor prognosis. It is characterized by neovascularization in the angle of the anterior chamber, which impairs aqueous outflow and in presence of an open angle glaucoma, and later contracts to a secondary angle glaucoma. The causes of the neovascular glaucoma, something is wrong, I don't know. Is central or branch retinal vein occlusion. It's a third of the neovascular glaucoma occurs at diabetic patients after more than 10 years of diabetes. And other causes of neovascular glaucoma are ocular ischemic syndrome, central obstruction of the artery, chronic arterial detachment, retinal or choroidal tumors, and not in the last time, the Sturge-Weber-Krabbe syndrome. The physiopathological mechanism is retinal ischemia, induced production of vasoproliferative factors such as vascular endothelial growth factors. Posterior segment ischemia drives to the neovascularization of the angle, leading to the fibrovascular membrane. Initially, the overlays of the trabecular meshwork is so that the angle appears open, but with time the membrane contracts and to zip the angle shut. The aim of our study is to show different methods of treatment, to elaborate an algorithm and on follow-up in neovascular glaucoma. We studied 56 cases of neovascular glaucoma, which were operated in our department. The treatment was medical, laser, and surgical treatment. You can see here our algorithm in the treatment of neovascular glaucoma, like medical, laser, and surgical. Medical is local and systemic treatment. Local medical corneal control of intraocular pressure, anti-inflammatory agents, and cycloplegic agents. The systemic treatment is with acetazolamide, osmotic agents, antalgic agents, and anti-inflammatory agents. Like laser treatment, we perform laser pan-photocoagulation or sectorial photocoagulation. Surgical treatment is we perform the trabeculectomy with antimetabolites like mitomycin C or 5-fluorouracil, and some cases with antifibrotic agents like interferon alpha 2B. This is our algorithm of treatment in the neovascular glaucoma. We will something like that. We lost the connection.
Yes, we have the connection. We see and hear you.
It's okay with connection here. I don't know what's happened.
Doamnă profesor, încercați să închideți prezentarea și să o reporniți, că se mai întâmplă. Așa e cu tehnica.
No.
Eu îmi cer scuze că intervin. Închideți nu share-ul, dar însăși prezentarea. Acolo în bara de jos, vedeți, este prezentarea dumneavoastră. PowerPoint. Click dreapta pe ea. Close window. Așteptăm să se închidă. Da, închideți procesul. End proces. Copiați-o pe masa de lucru. Copiați-o pe desktop ca să nu apară...
I understood. Desktop. Okay.
Deschideți-o de aici.
Da, de pe flash-uri de mult, adică se mai întâmplă așa situații. Prezentarea se vede.
Ok. Mă auziți?
Sigur, vă auzim și vă vedem.
We analyzed the etiology of neovascular glaucoma, the role of efficacy of the anti-glaucomatous surgery, and the surgical technique used. We analyzed also the efficacy of anti-VEGF factor used, the fragment of the trabecle excited from the during the operation was examined histopathological, and in all cases we performed trabeculectomy with antimetabolites, mitomycin C, 5-fluorouracil, and antifibrotic agents like interferon alpha-2b. Besides the surgical procedure, we associated the sectorial or panretinal photocoagulation and intravitreal injection with bevacizumab and aflibercept. Cyclophotocoagulation with micropulse transcranial laser therapy may be a solution also. In most cases, we manage the preservative the remaining vision and reduce the pain. Management options as for neovascularization anti-VEGF therapy have been shown to have a significant impact in neovascularization, retinal ablation, laser panphotocoagulation, and for IOP, cycloplegic with topical steroid of ocular hypotensive agents, and if medical treatment falls, trabeculectomy with antimetabolites or cyclodistraction transcleral cyclophotocoagulation. For pain in the eye is if the eye is blind and painful, consider retrobulbar alcohol or distillation or enucleation. Medical therapy was pharmacological treatment for elevated eye phase was usually performed with aqueous humor suppressants. Local ocular hypotensive therapy was done with fixed combination of carbonic anhydrase inhibitors, beta blocks, alpha adrenergic antagonists. Do not use prostaglandin analog to rest the ciliary body and reduce the pain on administrated atropine, cyclopentolate, and topical with anti-inflammatory agents, steroid or non-steroidal. Systemic therapy with acetazolamide to reduce the production of aqueous humor and osmotic agents to reduce the volume of vitreous. Antalgic agents and anti-inflammatory agents were used to reduce inflammation and pain. Laser therapy, we had, in all cases, we perform laser therapy, sectorial or pan photocoagulation. Laser therapy was combined with the intraocular injection with anti-VEGF factors, and we use the bevacizumab or aflibercept, and now why not brolucizumab? It's a new opportunity for intraocular injection in neovascular glaucoma. Surgical therapy was the trabeculectomy with application of antimetabolites and antifibrotics on the trabecular measure. The antimetabolites was, how I said, mitomycin C, 5-fluorouracil, and the antifibrotic agent was interferon alpha-2b. After I made a trapezoidal scleral flap with a length of 8 to 10 millimeter and within 4 to 6 millimeter, preferably a thickness of about a third of the thickness of the sclera. We believe that a thin flap is useful in maintaining the filtrate and in the long run. We applied the antimetabolites or antifibrotic agents soaked in a cotton swab for 3 minutes. Why not, we think, in the future to make a combination between these two agents like antimetabolite and antifibrotic agents. In 30 cases, we managed to keep the vision clear and reduce the pain, and in 11 cases, without light perception, we reduce the pain and maintaining the anatomical integrity of the eyeball, so that the quality of life of patient was improved. The 10 cases with laser cyclo G6 treatment are under investigation. This transleral cyclophotocoagulation, it's an opportunity in the treatment of neovascular glaucoma because it's non-invasive, easy to perform, and repetitive method. The results are encouraging. The frequency of intravitreal injection was related to the examination of the fundus and the thickness of the central retina, the macula. No early than 1 month. The trabecular part was sent for the analysis. The histopathologic analysis was performed in the department of clinical hospital, and this small fragment show us that anti-inflammatory. Here we have the analysis for after administration the interferon alpha 2b, and here is show us that inflammation decrease, and we hope to be good for protection the filtration. Results was good after trabeculectomy. 3 cases required reintervention. We must repeat trabeculectomy, but the severe rubeosis disappeared and was significantly reduced after surgery with interferon alpha 2b and intraocular injection. Here are some of our cases. This patient was operated in the both eyes with neovascular glaucoma with about 15 years ago. Here is another one. Here is a patient with ocular ischemic syndrome, and you can see the filtration blend, and you can see the OCT of the anterior segment to and see the filtration blend. In conclusion, neovascular glaucoma is a very difficult pathology. It's very hard to manage. The treatment should begin very, very early. The use of pan-retinal photocoagulation and intravitreal injection can reduce the neovascularization of the iris and angle and normalize the intraocular pressure. Intraocular injection with anti-VEGF factor must be done in the surgical management of neovascular glaucoma for good results. Surgery with antimetabolites and antifibrotic agent is important to avoid the bleb fibrosis. Transscleral cyclophotocoagulation can be an opportunity. This was my presentation. I want to invite all the participants to this congress in October, in the last week of November, sorry, to our annual meeting of the representative contact lenses in Romania. It will be the Hotel Ramada, 26, 27, and 28 of November. The theme is therapeutic role of contact lenses, the condition of the ocular surface in the pandemic with COVID-19, and all other topics. Thank you for your kind attention. If there are questions, I am here to answer.
I think we will have the questions at the end of the session.
Yes, okay. Much better.
Yeah. It's special to me to introduce the next topic and also the next speaker. In 2017, we created an optometrist education at the State of Medical University here in Chisinau. And the students graduated this summer, and I'm very happy about this one. For a long time, for many years, I have been the only optometrist in Moldova. So it's a pleasure to introduce to you the next topic, the role of an optometrist in medical system of Republic of Moldova. And Tatiana Gavriliuk, in collaboration with Tatiana Gidrimsky and me, and the Low Vision Center. So please, Tatiana, welcome.
Hello, everyone. Good morning. Thank you for the kind introduction for today's meeting. I will try to share my screen right away. Could you confirm if you see my screen? Yeah.
It's okay.
Thank you.
Yes, it is.
So, hello one more time. Today I'm here to talk to you about the role of an optometrist in medical system of the Republic of Moldova. As it's been mentioned, in 2017, optometry specialty was established at the Nicolae Timițeanu State University of Medicine and Pharmacy of the Republic of Moldova. And the first class of optometrists graduated in June 2021, me being one of these freshly graduated optometrists. If we take a look at the global situation, according to World Report on Vision, globally 2.2 billion people live with a vision impairment. In at least 1 billion of these cases, vision impairment could have been prevented or has yet to be addressed. So we have here 123 million of these cases represent unaddressed refractive errors, and unaddressed presbyopia constitute 826 million. In this context, we can say that the optometrist would be the key to success for prevention. Talking about the premises of optometry establishment in Moldova, it's highlighted the fact that the fact of high prevalence of visual impairments and increasing incidence of eye diseases during 2015-2020, according to our National Agency of Public Health. And if we take a look at the Vision Atlas in 2020, we can say that in the Republic of Moldova, there were an estimated number of 830,000 people with vision loss. Of these, 19,000 people were blind. In comparison with neighboring countries, Romania, Ukraine, Republic of Moldova is distinguished. However, it is negatively distinguished, we can say, by its higher prevalence of vision loss of 22%, followed by Ukraine with a prevalence of 19% and Romania with 18%. Meanwhile, Norway registers just 6%. Comparing these Eastern European countries to Northern or Western countries, Western European countries, we see a significant contrast. In this diagram, the distribution is made according to visual acuity. Objective of the study to describe the role of an optometrist in the assessment of visual impairments, to assess the public's knowledge and attitude regarding the new specialty. A descriptive sociological study was performed based on a population random questionnaire. So the questionnaire was completed by 110 people. 61% represented females, and the rest of them 39% males. Participants from urban areas constitute 60%, and from rural areas we had about 34%. Respondents' clinical profile showed previous spectacle or contact lens wear in 59%, and other 40% do not have such an experience. So we can conclude that more than half of our respondents had interacted with medical ophthalmological system of our country. The majority, 74% of the respondents, reported a high level of awareness of the optometry term, and only 25% had never interacted with the given term. Also, the respondents had a chance to choose the exclusive responsibilities of optometrists from their point of view in order to assess their knowledge of the difference between ophthalmologists and optometrists. I'm sorry. So we asked them if they know the difference between the ophthalmologist and optometrist at the end of the questionnaire. And at this point, 54% said that they know the difference. And out of these 54%, 96 people could have chose the right functional difference between ophthalmologist and optometrist. At this point, we can move to the conclusions. The last point, we can say that optometry as a healthcare field remains to be explored, as it's a new specialty in the Republic of Moldova. The evolution of optometry is accelerated all over the world. However, it is geographically disparate, as we saw, Eastern Europe and Western Europe, for example. Also, the study showed a relatively high level of public medical knowledge regarding optometry among people with higher medical degree. Also, there is an essential demand of more complex researches among people with variable representative sample. That concludes my talk for today. Thank you, everyone, for your kind attention.
Thank you very much, Tatiana. I'm proud.
Thank you.
Also, the next presentation is collaboration between Norway and Moldova, between Southeast University of Norway and Medical University in Chisinau. So the topic is surgery outcome modeling in concomitant esotropia treatment. It's a pilot study, and Ala Paduka will present. Thank you.
Good morning for everybody. Can you see my screen?
Sorry, I introduced the wrong person maybe, but in my program it says Ala.
Yes, but I will present this presentation.
Thank you.
Mm-hmm. Can you see my screen?
You see the screen?
Okay,
Yes. Okay.
thank you. So we will discuss about surgery outcome modeling in concomitant esotropia treatment, a pilot study. The main goal of strabismus surgery is to correct misaligned eyes and improve binocular vision. Therefore, the predictability of the surgical outcome depends on the assessment of the factors that might influence the outcome of the strabismus surgery. Von Graefe was the first who mentioned the dose-response relationship in strabismus, and von Fluke followed his ideas using the degree to millimeter ratio based on the notion that 5 degrees equals 1.1 millimeters on the surface of the globe. Since then, a lot of surgical formulas and tables have been developed and proposed to grow the predictability of strabismus surgery. However, there is still no consensus among strabismus surgeons on the dosage effect of recession or resection of extraocular muscles, and there is still disagreement about how much surgery is required for different types and degree of strabismus. The aim of our study is to propose and elaborate an postoperative angle of deviation predictive model using simple potential predictors for esotropia treatment. Methods. The analytical prospective clinical study was conducted from April 216 to July 219. On a sample of 160 patients with concomitant esotropia who underwent strabismus surgery in Republican Clinical Hospital Timofey Moshniaga and Children's Hospital Emelian Kotsaga from Republic of Moldova. The inclusion criteria were horizontal concomitant manifest strabismus who underwent a strabismus surgery within the study period. Exclusion criteria were pre-existing eye disease such as corneal opacity, cataract, congenital optic atrophy, or glaucoma, concomitant strabismus, patients who refused to take part in the research, and patients with less than 6 months after surgery intervention follow-up period. Data collection analysis included age at the time of surgery, gender, type of strabismus, pre- and post-operative deviation angle of squint, and 6 months follow-up, extraocular muscles recession and resection, rectus lateral muscles and medial rectus muscles tendon with a distance of insertion from the limbus measured with in millimeters. All patient underwent a full ophthalmic and orthoptic exam before the surgical correction. The prism cover test was used in order to measure the angle of deviation for both far and near fixation with an appropriate optical correction. The pre- and post-operative deviation was measured by the cover and cover test, simultaneous prism cover test, and under total dissociation by the alternate prism cover test. There are our results. The study pilot consists of 216 patients diagnosed with concomitant strabismus, 160 from them with esotropia, 56 with exotropia. The average age was 10.5 years. Here you can see the correlation analysis in the postoperator and preoperator angle with age, degree of myopia, recession and resection of extraocular muscles, and the lateral rectus muscles and medial rectus muscles. The results, correlation analysis named to identify potential predictors for esotropia surgery outcome, revealed the following significant associated with preoperative angle of squint, amblyopia degree, and extraocular muscle recession amount. The following mathematical expression was obtained. So we have esotropia surgery outcome, preoperative angle of deviation, extraocular muscle recession, and resection. The collinearity analysis showed that the prediction quality was not affected by the potential strong link between the model parameters. From a quantitative point of view, it was demonstrated by the coefficient standardization that the preoperative amount of deviation is the most important predictor, followed by the extraocular muscle resection amount and the extraocular muscle recession length. In conclusion, we can say that in esotropia cases, for every additional preoperative deviation degree, the expected postoperative amount of deviation increased by 0.85 on average by holding all the variables constant. For every additional extraocular muscle resection amount in millimeters, the expected postoperative deviation decreased by 1.01 on average, and for every additional extraocular muscle recession amount, the expected postoperative deviation decreases by 0.52 on average by holding all other variables constant. Thank you for your attention.
Thank you very much. The next presentation is from Sofia, Bulgaria, and the title is Pre-Medication and Sedation During Ophthalmic Surgery. I hope, yeah, now I see Dr. Kraleva, so please.
Hello. Just a second. I hope you see my presentation. Good morning, dear colleagues.
No, we cannot see.
You cannot see. Oh, how unfortunate. Share screen.
You have to select from the windows that it's open your presentation. And after this, push once again share.
Okay. I pushed it, but do you see my screen?
No, not yet. Okay, so let's try it once again. Please, open your presentation and let it open. And after this, you press the green button from the Zoom meeting, share screen, and it will open a window, and you have to select your presentation and to press share.
No, I'm sorry. Select window. Okay.
And shares the blue button. Press it.
You are sharing another. No, it's not happening. Select window.
You are sharing. Okay.
Wait.
And now select yes. Great.
Okay.
Okay. And just to put it.
Excuse me, I'm new for all these Zoom congresses.
Okay. Thank you.
So dear colleagues. My name is Julia Kraleva, and as an anesthesiologist, I represent Specialized Eye Hospital Academic Pashev in Sofia. It is a pleasure for our team to share the practice of premedication and sedation in our clinic. So this slide was intentionally chosen to stress on the fact that during pandemic we all have experienced rise of anxiety, and this was even more true for elderly people, especially with comorbidities present for surgery. We felt like we need to share our experience in dealing with nervous and tense patients scheduled for operation. There are some operation procedures conducted in our facility that required some sort of an anxiolysis. Cataract surgery, the most abundant procedure, vitreoretinal, cornea transplantation, glaucoma drainage, and eyelid reconstructive and aesthetic surgery. There was one patient with a penetrating eye injury. Providing sedation and premedication for our patients, we kept in mind several goals: safely eliminating tension and anxiety in polymorbid aged patients, providing comfort on the operating table for those suffering from chronic osteoarthritis pain, enabling the surgeon to operate on cooperative patients with no sudden fluctuations in consciousness, and ensuring rapid return to preoperative state. Preoperative and intraoperative levels of anxiety were assessed through a survey conducted in 2 stages during pre-anesthesia consultation and post-operatively. 0 to 10 scale was used to assess the level of anxiety. Non-invasive blood pressure and heart rate values were registered and on admission and immediately preoperatively. Patients taking medication for non-anxiety disorders were excluded from the study. So among 746 patients admitted for operation, 13% reported moderate to high levels of anxiety. Mildly anxious patients, 32%, received premedications only. Patients with 9 to 10 points were considered for general anesthesia. Mildly anxious patients with stable blood pressure were premedicated with hydroxyzine. It's a first-generation antihistamine. Because of its sedative properties, lack of side effects in small doses, and the ability for patients to return in a daily routine safely the same day. Hypertensive patients were actively treated with combination of hydroxyzine and clonidine, and patients with history of chronic pain, of osteoarthritis origin, and no anxiety were treated with paracetamol, combination drug of tramadol and paracetamol. Low doses early onset sedation was performed for moderately and highly anxious patients. Basic cardiovascular and respiratory assessment took place at admission, peri and intraoperatively. Well-known features of the medications midazolam and fentanyl, reasonable price and advantages of short action drove our choice to midazolam and fentanyl. This combination were preferred because of non-compliant experience with a single drug technique. So midazolam is a benzodiazepine inhibiting GABA mediation in central nervous system. It offers sedation, anxiolysis, hypnosis, and retrograde amnesia. It metabolizes with no active metabolites, what was beneficial if you want a rapid recovery and avoid hangover effect. And fentanyl complements midazolam, producing state of euphoria and analgesia, acting predominantly via mu receptors. In order to avoid deep sedation with respiratory depression and loss of protective reflexes, we performed titration of midazolam and fentanyl, starting 30 to 60 minutes before operation, and the doses used were 10 to 25 micrograms of fentanyl and 250 to 500 micrograms of midazolam. Thus, the study of the state of tranquility and relaxation was achieved without suppressing breathing and consciousness. Patients reported reduced level of anxiety by 2 to 6 points and ability to go calmly through regional anesthesia application, the preparation of the operative field, and the operation itself. No nausea and vomiting was reported. Surgeons were satisfied with a stable level of patient's consciousness and cooperation without episodes of abrupt arousal from deep sleep with sudden movements. Now, our conclusions is that intentional screening for patients with preoperative anxiety and the applications of early onset low doses sedation can meet the needs of the patients and the surgeons and also be safe. And now we set ourselves a task of investigating premedication with gabapentin for ophthalmic surgery patients and compare effect of hydroxyzine and gabapentin. Thank you for your attention, and I think I must click on end of presentation now. Thank you very much.
Thank you to you for a nice presentation. The next one is from Turkey. No, I'm a bit confused by all the names, but the topic is ophthalmological situation of patients with chronic renal failure undergoing hemodialysis. Please. You are welcome. Is somebody from Turkey ready?
Hasbjörn, maybe you can read the name.
It's Mahmoud Ulusoy.
I don't know, but unfortunately, I cannot see anyone from the group of the author being present today at our meeting.
Okay, so we can continue to the next one.
Yes, I think yes.
Okay, but will you, Professor Stanila, make the presentation?
Yes, the next speaker is from Republic Moldova. Alice in the Wonderland Syndrome as Aura of Migraine. Cristina Szczerbatyuk.
Hello once more. Can you see my screen?
Yes, we can.
Yes, we can.
Okay, thank you. I will speak about migraine and about aura of migraine. So one of the migraines aura, it's Alice in Wonderland syndrome. Few words about migraine. Migraine is one of the common types of headache disorders that can present with a wide variety of symptoms, usually occurs as recurrent attacks. A migraine attack can last from hours to days. A typical migraine attack passes through 4 phases: prodromal phases, aura phase, headache phase, and the postdromal phase. About aura phase. Migraine aura is a transient neurological symptom that most commonly involves the visual fields and occurs before the headache phase. Aura is seen in 25% of patients with migraine, can precede the headache, or sometimes headaches start along with aura. Visual aura can be in the form of flickering, jagged arc of light, bright lines, or a blind spot in the visual field, and Alice in Wonderland syndrome. Some patients experience isolated aura without headaches. This is called acephalgic migraine. In 1955, English psychiatrist John Todd defined the Alice in Wonderland syndrome as self-experienced proximal body image illusions involving distortions of the size, mass, or shape of the patient's own body or its position in space, often accompanied by depersonalization or derealization. Alice in Wonderland syndrome may be accompanied by visual perceptual disorders like micropsia, macropsia, telopsia, epilepsia. Alice in Wonderland syndrome is a little understood condition. Many people who suffer from migraine have this syndrome. Unfortunately, these patients either do not share the symptoms with their doctors, or if they do, they are dismissed by the physician, especially those that not trained in migraine medicine. We can see that to diagnose this syndrome, we can use CT and MRI, but this investigation usually not show any alternations. Single photon emission CT studies have been conducted, which revealed hypoperfusion of the temporal lobes and around the optic tract and its connection. Visual evoked potentials show increased amplitude that could be the driver for transient ischemia localized in the optic tract or an imbalance in neurotransmitters in the central nervous system. Functional magnetic resonance imaging have identified an occipital hypoactivation and hyperactivation of a parietal lobe when micropsia occurs. Valencia et al. Suggested that the following diagnostic criteria for Alice in Wonderland syndrome-associated migraine can be one or more episodes of body distortion or metamorphopsia. Duration of this episode must be more than 30 minutes, less than 30 minutes, accompanied by headache or with a history of migraine, a normal MRI, normal cerebrospinal fluid, and electroencephalogram. Alice syndrome is the most commonly reported in children. Reported causes include migraine, 27%, infection, especially with Epstein-Barr virus, 15.7%, epilepsy, depression, toxic and febrile delirium. I had a few patients after COVID toxic COVID intoxication and delirium that had these symptoms. Additionally, in declining order of prevalence, there are brain injuries, drugs, psychotropic substance, psychiatric disorders, and epilepsy. I will present two patients. The first patient had associated of migraine headache with aura and Alice in Wonderland syndrome in a 7-year-old boy suffering from the crisis of vertigo, weakness, micropsia, macropsia, diplopia, 15 minutes duration, followed by migraine headache. The frequency of attacks was monthly. Last episodes were accompanied by symptoms such as deformation of figures and objects, small or large in shape. Although ophthalmological examination, neurological examination, routine blood testing, and MRI showed no abnormalities. So this patient come to ophthalmologic consulting because his parents thought that he has some ophthalmologic disease. Another patient, 15 years old child, experienced before migraine headache, visual hallucinations, changes in size, distance, or the position of static. Alternation in hearing and tactile perception episodes, episodes of depersonalization and derealization. Ophthalmologic exam, neurological exam, routine blood testing, and MRI showed no abnormalities. So these patients were directed to neurologist, and neurologist just put the diagnosis of migraine with aura, with Alice in Wonderland syndrome. That's all. If you have any question, I can answer.
I think when we finish the session, it's we have for all speakers.
Okay.
I think. Thank you very much. The next one, I think we are clever on keeping the time. The next one is atropine used in myopia control. And it's you again, I think.
Yes, it's me again, yes.
Please, thank you.
You can see my screen, yes?
Yes, we can.
Okay. A few words about myopia. Myopia is a multifactorial disease caused by the uncoordination development of the various parts of the eyeball, which is affected by the environment and genes. It is the most common eye disease in children and adolescents and has grown rapidly worldwide over the past few decades. Myopia have an impact on children's academic performance, children's physical activity, psychological development, and employment choices. Children with an early onset of myopia, always accompanied with high progression rates, have a greater risk of glaucoma, cataract, myopic maculopathy, retinal detachment, and choroidal neovascularization. There are several approaches to slow down the progression of myopia. First is increase outdoor activities and reduce near work or study. Could delay the progress of myopia, but the outdoor time was limited because of the high educational pressure. Second, people with myopia displayed relative peripheral hyperopia. Orthokeratology lens could shift the relative peripheral refraction in the myopic direction, slow the axial elongation, and thus help to delay the myopia progression. However, orthokeratology lens is not appropriate for all the patients, such as patients with severe dry eye or keratitis. Anticholinergics are a class of drugs which block the action of acetylcholine at the muscarinic receptors on the structures with parasympathetic innervation and smooth muscles. Acetylcholine plays an important role in the developing retina and regulates the growth of the eye. Atropine was initially used for myopia control because of historical reasons, since excessive accommodation by the eye responsible for myopia. Atropines cause cycloplegia by paralyzing the smooth ciliary muscle temporarily. Later studies implicated non-accommodative mechanism in the cause of myopia and showed that eyes unable to accommodate, either due to lesion of the Edinger-Westphal nucleus or damage of optic nerve, also developed myopia. Atropine could have biochemical effects on the retina or sclera, which in turn affect remodeling of the sclera. Atropine may function at a relatively low dose via a neurochemical cascade, which begin at M1 to 4 receptors in the retina, likely in amacrine cells. Other theories suggest that popular dilation may lead to increased ultraviolet exposure, which may limit axial elongation. Although many studies have demonstrated the effectiveness of atropine in controlling myopia, a recent 2-year follow-up observation in children in the United States found that 0.01% atropine could effectively control the progression of myopia. A meta-analysis published last year verified the effectiveness of this concentration of atropine on myopia, but it did not show the effectiveness of other doses. Kinoshita report that the combination of application of 0.01 atropine eye drops and orthokeratology can significantly slow the axis elongation compared to the use of orthokeratology alone. So our methods include atropine 0.01 eye drops % eye drops have been used for myopia control for 1 year in a pilot study involving 50 children. Children aged 6 to 16 years with myopic refraction of at least 1 dioptria in both eyes, astigmatism of less than 1.5 dioptria, and documented myopia progression of at least 0.5 dioptries in the past 1 year were enrolled in the study. All subjects were prescribed with best corrected spectacles. Outdoor time and near work time were administered to parents. Outdoor activities include time spent on sport and leisure. Near work include time on homework, phone, computer, video games, watching TV. Myopia progression in each eye was further categorized as mild, moderate, or severe. It was found that in 1 year period, atropine 0.01% eye drops slowed myopia progression to 0.3 dioptries compared with 0.9 in the control group, with a reduction in the myopia progression. Axial length change at 1 year was larger in the control group, 0.3 millimeters, than in the study group, 0.19 millimeters. As a conclusion, atropine in concentration of 0.01% was well tolerated without apparent adverse effect on the quality of life and was effective in controlling myopia progression and axial elongation over a period of 1 eye. Thank you for your attention.
Thanks again. Thank you very much. So nice. Then it's from Moldova. Visual disturbances following by MTBI in school-age children. Dr. Victoria Beria.
Hello, can you hear me?
Absolutely.
Okay, so as I start. Okay, are you able to see my screen?
We are. We see it.
Okay, let me make it. Oh, okay then.
Like this.
Okay. Hello, one more time. I'm happy to attend this meeting. Hope you're gonna find my report informative and interesting. So as we start, I'd like to speak today about visual disturbances that can occur in a child after head trauma, in a school-aged child, to be more precise. To speak of traumatic brain injury, we should say that it's one of the most common cause of neurological that may occur in childhood and adolescence than in any other time of their life. As we speak of experiencing concussion, we may also outline that in about 90% person would actually occur a concussion during the age of adolescence or childhood. For gender separation, we can speak that most affected would be boys ranged from 10 till 19 years, and but also young females can be involved. Okay, let me get this out. Yeah, that's better. As pathophysiology occurs, we say that pediatric brain injury has different mechanical and compositional properties. We speak of a possibility of brain tissue displacement more often and a shear injury. These properties can amplify the complicated neurometabolical cascade that usually comes after a brain injury and would make a more prolonged recovery in this kind of children. As for the future, the prefrontal cortex, the region responsible for executive function, may be also involved. Visual consequences affect the input of visual information, so it may prevent the patient from having clear and single vision at all distances. A poor visual impulse would actually go on with undoubtedly effect of visual information processing. Starting from this idea, we decided to make research that would occur two kind of groups. The ones involved in the research group with the patients that actually undergone a mild TBI with visual consequences, visual effects, disturbances. And in the control group, we have involved patients that would come to the outcare department that would just have visual disturbances, but no mild TBI in the last 5 years. We focused on an examination plan that would be mostly simple, mostly opened and accessible to doctors, since our goal would be probably reevaluating the protocol of a multi-TBI patient, maybe with its additional information accompanying. So we would concentrate on a visual acuity examination, ocular movement, biomicroscopy, binocularity, visual field, color test, ophthalmoscopy, and also visual evoked potential. Referring to the type of trauma, we found that mostly the patients have undergone trauma lesion localized in about 40%, and lymphatic lesion follow cranium deformities and clear concussion along with epidural hemorrhages. The natures of trauma have been classified as following, being falling from heights, vehicle accidents, falling objects, and sport-related activities. All the patients have undergone a fast and easy neurological examination. Since it is a child, it is quite difficult to have a lot of spare time during the examination. So we will define speaking deficiencies in about 36% of the cases, while for the others of 63 would be clear but delayed speech. A peripheral nervous system examination would reveal an average disturbance in about 40%, while in another 60%, no problems have been determined. The examination of the cranial nerves revealed some disturbances at the level of the oculomotor trochlear and abducens nerve, with a decrease of ocular motility almost in all of the axes. The examination of general motility would reveal a peripheral paresis, and 6% in 57 had a complete peripheral motion, while in 18 patients it was not possible to evaluate. Examination of vestibular function have been undergone in 25 patients, thus with positive results determining in 80%. So we had some pathological positive reflexes, but they were in about 37% with a slight tremor. All of the patients have undergone CT scans and MRI, so we had mostly cranial and bones fracture, but these fractures were linear, so without damage of the brain tissue. In another 15 cases, we had absolutely no changes, and just in slight 46%, we had brain hematoma and gray matter hemorrhage. Examination started with visual acuity. It has been undergone using a Snellen chart and psychoplegic refraction. So as you see, visual acuity has been affected in the acute stage after the multi-BA, resulting in about less than 50% in mostly 90% of the cases. But after 4 to 6 months, we have observed that the visual acuity has been improved very good. So it has been resulting in about 90% of the patient having an acuity of about 100%. Refraction status showed slight hyperopia from the start, and this evolution has been determined and seen also in about 5 to 6 months after the TBI. The motility showed mostly down gaze deficiency, an up gaze deficiency, with also the affection of the other gazes. Binocularity test would have a positive result about 40%. As well, ophthalmoscopical findings we may outline that in about 50%, we had no changes, just a slight venous congestion. So that is why a multi-BI patient would not be evaluated just from the point of view, does he have a papilledema or not? The inability of children to self-assess and report symptoms after brain injury can lead to misdiagnosis of visual disturbances and a poor prognosis. As investigating the visual acuity loss in children, our primary goal was to establish whether changes that appear may be considered permanent and important to be treated by vision therapy or glasses prescription. Visual field examination usually showed depression of the sensibility of the entire area. We didn't find some specific scotomas or hemifield loss. As you can see, we concentrated more on the fact this actual examination be reliable, and the visualization loss actually quite disappointed us from the start, because all of them had mostly a fixation loss. But on the other part, the false positive catch and the negative catches were quite good, so we can say that this is a reliable examination. This is a case of a patient that had traumatic neuropathy that at the stage when this field has been evaluated, the patient had the visual acuity of about 10% with no exotropia, but with no response on the visual field examination and also on the visual evoked potential. Unfortunately, in about 4 to 6 months, we had already the exotropia, the secondary strabismus, and we also had the signs of optic nerve atrophy on the ophthalmoscope. The test for the constant sensitivity usually indicates a good and reliable criteria in most of the patients. We have found a small difference between eyes, mostly on the left eye, but with no predilection for the trauma location. Ophthalmoscopy image showed mostly difference of the arteries versus veins ratio with a persisting vessel congestion. As you can see, here is the scale for the constant sensitivity, because it looks quite good. As the visual evoked potential, we have examined a lot of criteria, but we have concentrated on the P wave on this matter, and we can say that it has been a decreased wave latency over here, along with the decreased wave amplitude. So this might show that even if we have a multi-bay, we still have the affection of the optic tracts and nerves. Concerning the topography, we will say that in about 60% we had normal values. So even if the P wave was decreased, there was not a criteria for pathology. But in about 21%, we had also a pre-chiasmal lesion of optic pathways, most on the left part. And starting from 4 to 8%, we have lesions of optic pathways on the right and on the left part. So as conclusion, our findings that visual vestibular processing deficits are present subacutely following mild traumatic brain injuries. Visual acuity is affected primarily after head trauma, although it has big chances to get result with the vision therapy or without in a time period of about 6 months after the trauma. Autorefraction data usually will reveal slight hyperopia with a possible astigmatic component range between 1 to 3 diopters. Less of patients require glasses corrections as their return to school is delayed due to neurological status, although it may be considered prescription for the near-work optic correction for the comfort of the child. Almost a half of patients undergoing a visual field analysis after head trauma present medium pattern defect and average defect that being associated with a possible general depression. The defect graph along with the decibel presentation scale would be an easy feature for suspected visual field defects. Contrast sensitivity test can be useful in determining visual disturbances since it's a very simple examination and very interesting for the children. Ophthalmoscopic findings appear to be less evident after mild head trauma than other visual disturbances. Thus, we may not rely on them as a unique criteria while establishing the gravity of trauma complications. A visually evoked examination potential would be a quite interesting and informative examination. We hope to make it more accessible, to get more experience in that, and to use it in more children that would be affected from mild TBI. Thank you very much for your attention.
Thank you for an informative presentation.
Thank you.
We are passing on to high degree myopia correction by Dr. Julia Tanukova.
Good morning. Do you hear me?
We hear you.
Do you see my screen?
Yes, it's nice.
My name is Tanukova Yulia, and I represent the theme, the high degree myopia correction. Myopia remains one of the most pressing problems of modern ophthalmology. This is due to widespread occurrence of myopia and its early manifestation, visual impairment up to the limitation of sports and in the choice of profession. Today, there are about 1.6 billion people with myopia in the world, and the number is expected to double in 2030 to 3,361 million, increasing the high degree myopia up to 517 million. By 2040, up to the 4,089 million, high degree myopia up to 696 million. And in 2015, up to 4,758 million people, and high degree myopia up to 938 million. The methods of surgical correction of myopia include keratorefractive and intraocular correction. The most common keratorefractive methods are photorefractive keratectomy and laser-assisted keratomylosis. In photorefractive keratectomy method allows to correct up to 28 diopters, but this method is characterized by a painful postoperative period, slow recovery, and a high risk of complications, for example, in the form of epithelial fibroplasia. With the introduction of LASIK technology, similar problems were solved. Success in patients with a high myopia is limited to 10-30 diopters due to basiline corneal thickness and curvature. Intraocular correction is based on replacing the native lens with an artificial intraocular lens or the required diopter. This type of refractive surgery is used mainly in the correction of myopia over -6 diopters. Goals: clinical evaluation of patients with a high myopia and evaluation of the results of keratorefractive correction using the LASIK method. Clinical evaluation of patients with a high myopia and evaluations of the results of refractive lens exchange. And comparative analysis of the results of keratorefractive correction by the LASIK method and refractive lens exchange. The examination of the patients was performed in ophthalmology department, ophthalmological center eye microsurgery in years 2018-2021, in which they were hospitalized for investigation and treatment. The study group consists of 129 patients, 211 eyes, with a high degree myopia, aged between 21 and 56 years, 45 men and 84 women, the average age being 43.67. Patient inclusion criteria was patient with a high degree myopia, higher than 6.25 diopters, and adults over 18 years of age. Exclusion criteria: patients with a low and moderate myopia, patients with the chronic inflammatory processes of the eye, conjunctivitis, keratitis, blepharitis, and uveitis, keratoconus, and severe ocular pathology, glaucoma, and diabetic retinopathy. Of all the patients with a high degree myopia, with myopia 6.25 to 10 diopters, 95 eyes, with myopia 10.25 to 30 diopters, 74 eyes, and with myopia higher than 30 diopters, 42 eyes. Patients were divided into 5 groups. In the first and the second group was used LASIK method, and in the group 3, 4, and 5, refractive lens replacement. In groups 1 and 2, patients underwent LASIK surgery using a microscan vision laser device and a Medlogic ML7 microkeraton. In the groups 3, 4, and 5, refractive lens replacement surgery was performed. The operations were performed using a Fokker hemisphere with the intraocular lens implantation for the corneal tunnel 2.75 millimeters on the Centuro microsurgical system. The high tissue formulas were used to calculate the intraocular lens diopter. The effectiveness of surgical intervention was assessed according to the data of visiometry and refractometry. Parameters such as efficacy and safety were also evaluated. The effectiveness of refractive surgery refers to the ratio of postoperative uncorrected visual acuity to preoperative best corrected visual acuity. Accordingly, the higher the obtained index, the more efficient the operation. And safety is the ratio of best corrected visual acuity after surgery to best corrected visual acuity before surgery. Safe operation is when the received index is higher or equal to 1. Of all the patients, there are 45 men and 84 women. More patients were at the group from 20 to 30 years, 41.1%, then the group 31-40 years, 34.1%, after group 41-50 years, 18.6%, and at last group 51-60 years, 6.2%. In this table is presented preoperative data of patients. Patients was divided into 5 groups depending on the correction method. Here are indicated the degree of myopia, uncorrected visual acuity and best corrected visual acuity before surgery, number of cases of eyes, and average age of each group, in every group. Preoperative refraction in group 1 was -7.67, in group 2 -10.96, in group 3 minus 8.22, in group 4 minus 11.87, and in group 5 minus 15.96. In this table is present postoperative data of patients, uncorrected visual acuity and best corrected visual acuity after surgery, efficiency index, and safety index. In figure number 6 is compared preoperative best corrective visual acuity and postoperative uncorrected visual acuity. And in figure number 7 is dynamics of efficiency and safety index. Postoperative refraction in group 1 was 0.11, in group 2 minus 0.12, in group 3 minus 0.55, in group 4 minus 0.61, and group 5 minus 0.71. This is pre- and postoperative refraction. Result. The highest postoperative uncorrected visual acuity was obtained in group 1, 0.91, postoperative spherical equivalent 0.11, efficiency index 1.21, safety index 1.3, and in group 2, 0.83, postoperative spherical equivalent minus 0.12, efficiency index 1.29, safety index 1.4, in which LASIK surgery was performed. Compared to group 3, uncorrected visual acuity 0.71, postoperative spherical equivalent minus 0.55, efficiency index 1.01, safety index 1.27, and group 4 in group 4 uncorrected visual acuity 0.7, postoperative spherical equivalent minus 0.61, efficiency index 1.09, safety index 1.38. In group 5, postoperative uncorrected visual acuity was 0.55, postoperative spherical equivalent minus 0.71, efficiency index 1.55, and safety index 2.32. Those LASIK correction has proven to be more effective, which may due to some errors in the calculation of EO in groups 3 and 4. In the conclusion, the results of the study reiterated that refractive surgery often knew effective and safe possibilities for the correction of high-degree myopia. It was found and confirmed by statistical analysis that the reduction of myopic refraction by LASIK method was achieved with a higher accuracy than in the case of extraction of the lens with the intraocular lens implant with refractive purpose. The LASIK refractive intervention allowed to obtain better results at the patients of the study in functional aspect compared to refractive lens exchange. That is statistically confirmed. And in the case of myopia greater than 30 diopters, the intervention of choice remains to be the extraction or the transparent lens with a pseudofab implant with refractive purpose. And that is all. Thank you for your attention.
Thank you very much. Very interesting. We have come to the last speech for this Congress. And the topic is quality of life in patients with diabetic retinopathy using SF36 health survey test. And the speaker is Dr. Veronika Kiska. Please.
Dear husband, unfortunately, Dr. Kiska won't present.
Okay.
So, yeah.
So then we has come to an end. and it's some question and answering session. So now, give the speakers some questions.
Yes, I have one question. Dear Chairman, I have one question to Dr. Julia Tanurkova. Can I?
Yes, please.
As this subject is very close for us, we do a lot of myopic patients with LASIK and with lens exchange and with phakic lenses. So there, I think when she says a PRK in -28, it was just mistake, and there should be another numbers. This is the first. Another is age in group 3, 4, and 5, age of patients. Is the young patients about 30, 35, you use a clear lens extraction exchange? And what I say, okay, yes, I cannot agree with the speaker that LASIK is more accurate than clear lens exchange. If you have a good equipment and you use a good formulas for this, you can get the emetropia or slight myopia according your wish and necessity of patients. Yes, I think it's, but anyway, thanks to Dr. Julia. That's all.
Thank you for your comment. I said that maybe there are some mistakes in calculation intraocular lenses in formulas, and maybe this was a problem with the results.
And what about the group 3, 4, and 5? You use this clear lens exchange in the young patients too?
No. The
young,
no.
I mean the 30, 35, because
no,
the
average age in these groups are 38, 40 years.
40. And why you don't use a phakic lens implantation? This is a group, very good group for the phakic lens implantation. What do you think about? Okay, you don't use, okay, but what do you think about it? What is more safe for these patients? Because
for the patients after 40 years.
No, usually they recommend it to use after 50 clear lens exchange. And before 50, it's better to use phakic lens because they always have secondary cataract. You should use a YAG laser. Then you have problems with vitreous, with retina. This is active people, like active life. And so I think there will be much more complications. Do you agree?
Dear professor, I will comment little because in the medical center, the doctors do the phakic implantation, but in this study, it's not included these cases. And it will only do some comparison of the results using these presented methods. And of course, in some cases, it's phakic implantation can be the best option. But in this case, it's only the material dedicated to this method and of these patients.
Okay, thank you.
Yeah. May I comment something?
May I comment something? Yes. I have one question to the professor also. What about the workshop? Is it canceled? Workshop about the contact lenses. My residents waiting.
Oh, it was in parallel actually, and it started at 9 and finished at 10, unfortunately.
Ah, it was another.
Yes, it was already. Yes, it was on another link. So.
Okay, thank you.
Can I have a comment, please? Can I have a comment, a question?
Yeah, go on.
Yes, please. Which kind? Can you tell me about phakic IOLs? Which kind of, which type of phakic IOL you use?
You mean you asking me, Professor?
Yes.
I use ICL from Star Company.
Yes. From which diopter?
From which diopter?
Yes.
Over the 6, 7, but the main thing is the age of the patient and anterior chamber depth.
Of course. It's an evaluation, of course. Only this, yes? This
What
type
do you
of
mean?
ICL?
Yes, only this. Now, yes. But about 20 years ago, we used the anterior chamber phakic lenses, but the results after 10 years was very poor.
Very poor, because endothelial cell was very. I had a patient recently. I had a patient operated 15 years ago, and now the endothelial cells are 1,000.
Remove the lens.
Yes, yes.
Don't wait when his vision goes down.
No, the vision is good, but
you should anyway. You should remove the lens.
Yes,
anyway.
It's not my case. He came to me for second opinion.
Okay.
And which type about the age of? Could you comment about the age of refractive lens exchange? Which is the age for you?
I think after 50, 55, because it's a very few years before to starting the cataract. So person will live with a phakic lens, I think, more than 5, 7, 10 years. So it's better to do it before 50. And after 50, you can use the clear lens exchange. It's my opinion.
Yes, I use clear lens extraction at about 40.
Mm-hmm. Okay.
And multifocal if possible, but not only always.
Can I have a question again about the same subject? Hello, everybody, and to Dr. Tonukova. And you said that the limit for LASIK is up to 13, which I find it too high. And for many doctors, the limit of LASIK is about 8, maybe 9 maximum, because if you go over this number, powers, you get a lot of flattening and you have to remove a lot of tissue. So,
I totally agree,
I think
Professor.
10
I totally
and 13
agree.
is too much.
I totally agree.
According to the thickness, Mahmoud, according to the thickness of the cornea.
Thickness, okay, I understand, but also the curvature of the cornea. If it is 40, for example, you cannot even
40,
do 8.
Sure. 40, no, but if you have 43, 44, you can. Sometimes decrease the pupil optical diameter also. The optical zone also.
Again, the international opinion is
yes, maybe
less than 10. I mean,
yes, maybe,
8,
but
maybe.
Sometimes I think according to the doctor's decision, and you can do sometimes when you have the good parameters. I mean, again, the thickness, curvature, and optic zone. You can move a little.
These patients are these patients are suitable for ICL. I don't think refractive lens exchange, is not indicated in, as you said, in younger patients because of the risk of retinal detachment in the long run. And so ICL is the best choice. And if for people over 8, 9.
But if the anterior chamber is less than 3 millimeters, what you can do?
Yes, but Dr. Dovali, Professor Dovali, in such cases, almost all of them have deep anterior chambers, very few of them have less than 3 or 2.8. Very few.
Yes, you're right. It's individual indications, very individual.
Yes. But when we go to hyperopic patients, and this is also another interesting subject, and I do a lot of refractive lens exchange for hyperopic patients, and because they are not suitable for ICL, most of them, because of their very shallow anterior chamber. For example, the patients come with thick glasses. They cannot use contact lenses, and I can do it even at the age of 30 or even younger, because if they are not using glasses for high hyperopia. What do you think about that?
Yes, you are absolutely right. The main is anterior chamber depth. It's very important. But in some cases, maybe it's wrong, maybe it's right. I don't know. We are just use the bioptic, where you can put the thin phakic lens and about 5 diopter you can cut with a LASIK. In hyperopic, I mean. Because LASIK can correct about 5 diopter plus. And all other you can put is the very thin phakic lens plus, I mean, and make the iridectomy. It's important.
As ICL, yes, Professor. ICL.
ICL and LASIK. Bioptic.
Yes, bioptic.
Yes, I don't understand. And if the anterior chamber is too shallow for ICL in a hyperopic patient, how can I put?
Yes, about if it's more than 2.5, I did it because when do the iridectomy, and you should do it, you no problem with pupil block.
Yes. Maybe I think in such a case I would do refractive lens exchange in such cases. Personally,
you can do. Yes, you are right. Yes. Absolutely. It's a choice of surgeon. Thank you, Mahmoud.
Merhaba, I cannot see your face on the.
You missed me?
Yes, I missed you because I cannot see you.
Yes, because is a summer house and without the tie.
You don't have camera?
No, I have camera.
No, he has no tie.
I have no tie.
I have no tie also, you know.
But you have very, very beautiful and very nice shirt. Nike.
Okay.
Thank you very much, Evgeny. Very good conference, very good congress. Thanks, everybody. And I think we should continue our congresses. Even pandemic, unfortunately, will be more years in the future. We hope no, but anyway, we should be ready. Thank you, everybody, for participate.
I want to thank you to all the speakers. It has been a pleasure to be together with you. I really wish you all the best. Take care.
Thank you.
Hope the pandemic will disappear so we can meet in real. I was together with you also in 2015 here in Chisinau. So,
Mr. Baketain, Hans, can I call you Hans? Just
of course, of course.
Yes, it's very interesting. It's my dream to be to have courses of optometrists and have the young optometrists in Georgia. We have no, unfortunately. And if it's possible, I would like to invite you personally to start this direction in our country. Thank you.
I talked to my friends and colleagues here in Moldova and in Norway too, because it is very important, this one.
Yes.
Dear Professor Dvali.
Что вы сказали?
I say only with us, only with our permission.
Yeah, sure. you will accompany Hans.
Hans Björn has the Moldavian citizen. Yes.
Yes, yes. Okay. We have very good relationships, good political relationships. So you can visit us. We will be very glad, and we will invite you for future, for sure.
Never say never. So,
okay, I would like to say a few words. I would like to thank Professor Bendelik for organizing the 19th Black Sea Ophthalmological Congress. I know that it is a very difficult job, and that you did it perfectly. And I'm very happy that there were a lot of presentations and a lot of discussions. And I think this was a very successful Congress. Although it was not a live Congress, it's a success for a virtual Congress. Congratulations, and I hope the next Congress will be a live Congress. And Professor Duali and Mircea, and maybe we should talk about the next Congress soon for the 2022.
Yes, we have to do it.
Wonderful,
yes.
Wonderful. Thank
yes.
you. Thank you.
Thank you.
Thank you. But before we will close the Congress, we offered we invite one of our sponsors and liquor company.
And Bendelik, I cannot also see your face. I cannot. Okay,
I'm
now
present.
I can see you. Yes, I see you. I see Alexander and you. Yes, okay.
Okay, we will offer the time for sponsors, and after this we will close the Congress with your permission, of course.
Okay, thank you.
Okay.
Thank you very much. Thank you very much.
Thank you.
I invite the liquor.
My name is Anna Sofian. I will speak Russian. Добрый день. Компания Lipar приветствует всех участников Конгресса. И я, Анна Софиян, представлю небольшую презентацию о новом препарате, который появился совсем недавно на рынке Молдовы. Препарат под названием, брендовым названием Z-Optic. Z-Optic является фиксированной комбинацией 1% бринзоламида и препарата 0,5% тимолола. Этот препарат является аналогом такого препарата, хорошо вам знакомого, как Азарго. Если говорить о Z-Optic, это препарат, предназначенный для лечения глаукомы. Современная концепция глаукомы говорит о том, что глаукома имеет много звеньев своего патогенеза и определяется как коллагеноз с иммуномеханизмом развития. Первичное звено патогенеза глаукомы – это глаукомная склеропатия. Вторичными звеньями патогенеза являются офтальмогипертензия, нарушение гемодинамики, окислительный стресс и глаукомная нейропатия. Если говорить о препарате выбора, который бы обладал такими свойствами, как снижение внутриглазного давления, улучшение кровоснабжения, имел бы антиоксидантное действие и имел также толерантный уровень среднесуточного колебания внутриглазного давления, препаратом выбора является Z-Optic. Если мы говорим о гипотензивном действии препарата, то здесь хотелось бы отметить о подавлении продукции водянистой влаги за счет того, что в комбинации, фиксированной комбинации брензоламид, высокоспецифичного ингибитора карбоангидразы и этимолола неселективного бета-адренергического блокатора.
Мы просим прощения, но мы не видим презентацию.
Сейчас.
Анна, вы просто открыли другое окошко. Вернитесь обратно к вашей презентации.
А сейчас видно?
Пока еще нет. Да, давайте еще один раз. И, только на презентации остановитесь.
Две секунды. Почему-то не выходит.
Она была открыта. Вы еще раз пройдите эти шаги.
Хорошо, 2 секунды.
И бумагу до сих включили.
А сейчас видно?
Пока нет.
Сейчас.
Загружается, сейчас должно появиться. Ждем. Все, есть.
Есть. Я прошу прощения за технические неполадки. Так, препарат Зитоптик, который только вышел на рынок Молдовы, является фиксированной комбинацией 1% брензоламида и 0,5% тимолола в виде суспензии. Предназначен препарат для местного лечения глаукомы. Зитоптик является аналогом оригинального препарата Азарга. Если говорить о современной концепция глаукомы определяет глаукому как коллагеноз аутоиммунным механизмом развития. Первичным звеном патогенеза глаукомы является глаукомная склеропатия. Вторичными звеньями патогенеза являются офтальмогипертензия, нарушение гемодинамики, окислительный стресс, глаукомная оптика, нейропатия. Для того, чтобы справиться со всеми со всеми изменениями вторичного патогенеза, необходимо для того, чтобы добиться эффекта, нужен препарат, который бы снижал внутриглазное давление, улучшал кровоснабжение глаза, имел антиоксидантное действие и имел толерантный уровень среднесуточного колебания внутриглазного давления. Препаратом выбора является Зитоптик. Если говорить о механизме гипотензивного действия, то, являясь фиксированной комбинатой, брензоламид как высокоспецифичный ингибитор карбоангидразы, этимолол как неселективный бета-адренергический блокатор подавляют продукцию водянистой влаги, так как они имеют две субстанции имеют аддитивный эффект. Тем самым Зитоптик снижает внутриглазное давление на 7-9 миллиметров ртутного столба, что в процентном соотношении составляет от 28 до 35%. Брензоламид усиливает глазной кровоток на уровне ретробульбарных сосудов, уменьшает время артериенозного пассажа, снижает сосудистое сопротивление току крови. Вазотропное действие брензоламида не зависит от офтальмотонуса. Брензоламид и тимолол имеют преимущество перед другими антиглаукомными препаратами в свете антиоксидантной и антирадикальной активности. Оба активных составляющих препарата зитоптик обеспечивают защиту трабекулярного эндотелия и клеток сетчатки от окислительного стресса. В качестве антиоксиданта препарат наиболее эффективен в начальных стадиях глаукомы, когда сохранены неповрежденные митохондрии и трабекула частично функционирует. Показаниями для назначения зитоптики является офтальмогипертензия и первичная открытоугольная глаукома при неэффективности составляющих монотерапии. Как резюме, препарат зитоптики является фиксированной комбинацией ингибитора карбонгидразы бринзоламид с бета-блокатором тимололом для лечения глаукомы. Препарат уменьшает продукцию внутриглазной жидкости двумя различными механизмами. Оказывает выраженный гипотензивный эффект, снижая внутриглазное давление на 35%. Применяется препарат 2 раза в день и позволяет контролировать уровень офтальмотонуса. Выраженно улучшает глазную гемодинамику без снижения перфузионного давления. Препарат зитоптик обладает высокой антиоксидантной активностью, что в совокупности с нормализацией офтальмотонуса и улучшением гемодинамики увеличивает центральную светочувствительность сетчатки, способствует стабилизации зрительных функций. Немаловажно, что препарат имеет толерантный уровень суточных колебаний внутриглазного давления. Также установлена хорошая переносимость препарата. Это достигается благодаря уровню pH препарата, близкому к pH слезы и отсутствию побочных эффектов. Также хотелось бы отметить, что у препарата зитоптик высокая комплаентность у больных с глаукомой. Препарат зитоптик производится из высококачественной европейской субстанции в полном соответствии с требованиями международных стандартов качества GMP. В частности, бринзоламид гидрохлорид, субстанция прима, приобретается в Испании, а тимолол малеат в Германии. Вашему вниманию будет представлено несколько исследований. Это сравнение фиксированных комбинаций бринзоламид-тимолол и дорзоламид-тимолол по таким показателям, как гипотензивная активность, местная переносимость и системная переносимость, побочные эффекты. На данном слайде вы видите 12-месячное исследование по показателю гипотензивной активности, где наглядно видно, что и одна фиксированная комбинация бринзоламид с тимололом и дорзоламид с тимололом хорошо понижает внутриглазное давление. Но все-таки гипотензивная активность, сравнимая с некоторым преимуществом в фиксированной комбинации бринзоламид-тимолол, в особенности в ночные часы. На данном слайде видно исследование по уровню глазного дискомфорта. Местная переносимость значительно лучше при применении фиксированной комбинации бринзоламид с тимололом, и это видно наглядно на данном графике. Следующее исследование проведено по показателю системной переносимости двух сравниваемых комбинаций. Здесь наглядно видно, что профиль безопасности лучше при применении фиксированной комбинации бринзоламид-тимолол. Это обусловлено суспензионной формой препарата. И в завершении маленькой презентации хотелось бы закончить высказыванием «Би дорси орли», зрение ограничено, слепота безограничена. Благодарю за внимание. Thank you for attention.
Well, thank you very well. Thank you very much. Now is the moment when we finish our program, we finish our discussion, and I like to bring my sincerely gratitude, many thanks for all participants, especially for the board of the Black Sea Ophthalmological Society, for involvement and for implication and support this meeting, because without one common participation, of course, we can't do this Congress. Thank you very much for to all moderators, and of course, thank you very much for all speakers, and of course, thank you very much for sponsors. And here is the first our pictures from the first day when we start our meeting, and of course, in this time we have many interesting presentation in this time of the Congress, and very interesting discussion, and
на него. Той само ми говори, а нямам картината.
And I like to say only in the first day, in the evening, when we opened the Congress, we had about 200 visitors, and yesterday it's about 400 visitors and participants and visitors, because it's the participants, somebody coming, somebody leave our page, the Congress, and after this, but in total it's about 400, around 400 visitors and participants. Well, thank you again, and I invite Professor Kaskaloglu. He told us start to say something about the Congress. Thank you very much. And if the Professor Kaskaloglu it's with us, I invite you.
Okay. I think you can hear me now.
Yes.
You can hear me now. Yes. Okay. And I would like to thank you very much again, Professor Bendelik, for organizing this Congress. I think it was successful, and it was very well organized, technically also, and the quality of the presentations were higher than our expectations, and there were good discussions, and people who attended the Congress, I think they learned something which they can use in their practices. Thank you very much again for your effort, and you are always looking for your support. We appreciate your support for the Black Sea Ophthalmological Congress, and I think your support will continue in the coming years, because you are the younger member of the BSOS.
Thank you very much. Thank you very much. And I invite Professor and academician Vasilieva from Bulgaria. Dear Professor Vasilieva. Okay. Maybe Professor Vasilia will connect us a little later. And I invite Professor Mircea Filip from Romania. Okay. And Professor Nadia Bobrova from Ukraine. Okay, and Professor Alexander Zabolotny from Russia.
Okay. Dear colleagues, this is days very useful with new knowledge and pleasant communication with colleagues. Thank you, Professor Evgeny Bendelik. Thank you to the organization for an excellent conference. See you soon.
Thank you very much. Thank you very much for support and participation. And I invite the Professor Dvali from Georgia. Thank you again for participation. And the colleague asked me about where will be the next Congress, Jubilary Congress.
We have no idea yet, and we'll talk about it.
Okay.
We'll talk about it.
Yeah. Thank you again. Thank you again.
Okay.
And I wish you the best day and the best nice day, nice yes.
Bye.
Kind wishes.
Bye.
Thank you very much. Thank you very much.
До свидания.
До свидания.
До свидания.
Большой привет всем офтальмологам Молдавии.
Спасибо.
Спасибо за теплый прием, который был несколько лет назад. Надеюсь, очно встретимся. Прекрасная страна, прекрасный город, прекрасные коллеги и прекрасный профессор Бенделик. Великолепный организатор.
Это не только я организовал, это вся наши коллеги. Спасибо. Мы всегда рады гостям. Спасибо большое. Thank you very much again, and we hope, as say Professor Kaskaloglu, we hope maybe in the future we can have the normal congress,
yes.
Not online.
I think the next one will be
yes.
a live congress. I think it will be a live congress. We'll see. We'll talk about with you again, and we'll see.
Thank you very much. Bye.
Bye.
Валерий, привет. Валерий, привет.
Здравствуйте. И спасибо за участие, и спасибо организатору.
Да, спасибо, Валерий, вам, я думаю, тоже принимали. Рад вас видеть. До встречи.
Я вас рад, слышал вас. Спасибо. Спасибо.
Вспоминаю нашу предыдущую конференцию у вас всегда. И ваш теплый прием.
Еще увидимся.
Надеюсь.
Надеемся.
До свидания.
Мира нам всем.
Да, это главное.
Да.
И здоровья.
И здоровья.